Good morning, all of you. Today I am going to start mineral, okay? Mineral metabolism, okay? Mineral metabolism I am going to start. So minerals are divided into major element and trace element, okay? Major elements are calcium. All of you can hear me?
Yes, ma'am.
Yes. Okay, major
Yes,
elements
sir.
are, yes. Okay, calcium, magnesium, phosphorus, sodium, potassium, and chloride and sulfur. Okay, these are the major elements, but because requirement, that amount that is required by the body, this calcium, magnesium, phosphorus, sodium, potassium, chloride, sulfur, a little bit higher concentration. Okay, and iron, iodine, copper, manganese, zinc, molybdenum, selenium, and fluoride, these are the trace element. Okay, they are required trace element. Why they are required? Very little bit, okay, very little amount. Okay, amount is 100 microgram per 100 microgram, not more than 100 microgram per deciliter or per 100 ml. Okay, 100 microgram per deciliter. Requirement is very less, so it is, these are known as minor element or trace. Okay, trace, very little bit. Okay, little amount. Okay, in microgram concentration, not more than 100 microgram per deciliter. Okay, that's why these are trace elements. Now today I am going to explain iron metabolism. Iron, it is very important. Okay, hemoglobin structure and function already finished. Hemoglobin, different types of hemoglobin variant also finished. There you got iron, right? There are different valencies of the iron according to the oxygenated, deoxygenated state, according to oxy and deoxyhemoglobin iron. You are little bit known about the iron. So first mineral I am going to start iron. It is very important. Okay, because it is required for synthesis of hemoglobin, isn't it? Synthesis of hemoglobin. Okay, some non-heme containing protein, like that I am going to explain. Okay, iron. So iron, distribution of the iron in the body, total body iron content is 3 to 5 gram. Out of that, 75% is in the blood and rest in the liver, bone marrow and muscle. Okay, rest of the 25% occurs in the liver, bone marrow and muscles, and major amounts 75% present in the blood. Iron is present in almost all cells. Okay, iron is present in almost all cell. Okay, it is maybe present inside some enzyme, in some in okay, inside some enzymes, some protein, like that. Okay, blood contain 14.5 gram of hemoglobin per 100 ml. Okay, 14.5 gram of hemoglobin per deciliter per 100 ml. That means, okay, 1 deciliter equal to 100 ml. About 75% of the total iron is in hemoglobin, isn't it? 75% of the total iron in the blood in the hemoglobin. Okay, and 5% in myoglobin and 15% in ferritin. Whatever it is present in the blood, okay, in the circulation, 75% in inside the hemoglobin, only 5% in myoglobin and 15% in ferritin. Okay, ferritin is the storage form of iron. Okay, storage form of iron, ferritin. Ferritin, it is a glycoprotein in nature, isn't it? Iron, 15% iron present in the inside the ferritin. So iron containing proteins, there are so many iron containing protein in our body. Some important one are iron containing protein. Again you can divide into heme containing protein. Okay, heme containing protein. Those iron containing protein we can subcategorize into heme containing protein, okay, and non-heme containing protein. All of you know the structure of hemoglobin, heme, isn't it? How tetracyclical tetrapyrrole ring, okay, in the central position is occupied by the iron, isn't it? And 4 valencies are completed by the pyrrole nitrogen, isn't it, of the pyrrole ring. Okay, and rest of the valencies are completed by the proximal and distal histidine. Okay, in case of oxygenated by oxygen in the 6 valency, already I have mentioned. Okay, already explained, all of you know. So iron containing protein you can subdivide it or subcategorize into heme containing protein. Okay, heme containing protein are hemoglobin. Number of iron atom 4, because in the hemoglobin there are presence of the 4 heme. Okay, one heme, each heme contain 1, so 4. Okay, each heme contain 1 iron. So how many total? 4. Okay, occurrence inside the RBC. Myoglobin, only 1 polypeptide chain, 1 heme, so 1 iron. It is present mostly in the muscle. Cytochrome oxidase. Cytochrome oxidase, it is a enzyme protein for the ETC, mitochondrial electron transfer chain or respiratory chain. Okay, cytochrome oxidase. Here also heme containing protein is there. Okay, number is 2 number of iron. Cytochrome B, cytochrome C1, these are all the protein in the respiratory chain or ETC, mitochondrial ETC. Okay, mitochondrial ETC also known as respiratory chain. Cytochrome B, cytochrome C1, cytochrome C, cytochrome B5. Okay, all of these 4 contain 1 each. Okay, and it's an important electron transfer protein in the ETC, electron transfer chain in the mitochondria. Then cytochrome P450, it is a very important enzyme for xenobiotic metabolism, isn't it? Cytochrome P450 present in the mitochondria or endoplasmic reticulum. Okay, it is responsible for the first phase reaction of xenobiotic metabolism. 450, it is very important. NADPase acts as a coenzyme here. Okay, cytochrome P450 is the enzyme in the first phase reaction of xenobiotic metabolism where NADPH okay, acts as a coenzyme. Okay, it present in the endoplasmic reticulum or and mitochondria. Okay, number of the iron atom 1. Catalase, okay, it is a free radical scavenger, okay, enzyme. Okay, catalase, iron atom 4, it present in RBC. Lactoperoxidase 1, it is present in the milk. Tryptophan pyrrolase, okay, tryptophan pyrrolase, it is responsible for tryptophan, amino acid tryptophan, no, aromatic amino acid tryptophan metabolism. Okay, tryptophan pyrrolase. So here it is 4. Okay, tryptophan pyrrolase, here presence of the iron atom is 4. Okay, present in the cytosol. Nitric oxide synthase. Endothelium, vascular endothelium, it is present. Nitric oxide synthase contain 1 iron atom. Okay, nitric oxide synthase, it is responsible for synthesis of the nitric oxide for the amino acid arginine. Okay, arginine. Okay, semi-essential amino acid present in the vascular endothelial bed. Okay, tryptophan pyrrolase responsible for tryptophan metabolism, isn't it? Tryptophan metabolism, tryptophan pyrrolase, isn't it? Which gives rise to NAD, okay, NADase like that. Okay, so iron containing protein. Now iron sulfur complexes. These are the non-heme. Okay, these are the heme containing protein. Okay, heme containing protein. Here it is the non-heme non-heme iron sulfur complexes, isn't it? Iron complexes 3 is a mitochondrial electron transfer chain ETC, isn't it? Presence in iron sulfur complexes, their presence of the 2 iron atom. Succinate dehydrogenase, this is also known as complex 2 in the ETC. Succinate dehydrogenase, it is known as complex 2. Okay, complex 2. Number of the iron atom 4, it is a important enzyme, complex 2 succinate dehydrogenase in mitochondrial ETC. Xanthine oxidase, okay, xanthine oxidase is responsible for purine metabolism. Okay, purine metabolized by the xanthine oxidase. Ultimately the product of purine metabolism is uric acid. Okay, here also presence of iron sulfur complexes and number of the iron atom is 8. It present in the liver. Non-heme iron containing protein. Here also non-heme iron containing protein. Aconitase. Aconitase is the enzyme of TCA cycle. Okay, TCA cycle. Aconitase. Okay, aconitase. By the aconitase, this citrate is metabolized to oxalosuccinate. Okay, oxalosuccinate. Okay, oxalosuccinate then again metabolized to oxalosuccinate, then isocitrate. Okay, first isocitrate, then oxalosuccinate, aconitase. Okay, number of iron atom 2. Okay, free hydroxylase 2 in the liver. Transferrin, it is iron carrier protein. Each molecule of transferrin can combine 2 ferric iron. Okay, so presence of the iron maximum 2 in each molecule of transferrin. It is important transporter of the iron, transferrin. Okay, it is present in the blood plasma. Ferritin, number of the iron atom is more because it is a storage form of the iron, 4000. It present in the different types of peripheral tissues. Okay, hemosiderin, this is also storage form of the iron. Okay, iron, it is excessive iron is stored as a hemosiderin, so number of the iron atom is uncountable, so it is present in the liver. Here the normal iron kinetics from the upper GI tract, it is absorbed from the diet, then it enters the enters the plasma or eliminated via excessive iron, eliminated via feces. And according to the body demand, it absorbed by the circulation. In the circulation, it is transported as a ferric state. Okay, ferric state, always remember it can absorb in ferrous state. Okay, because in the upper GI, okay, and in the intestinal epithelial cell, there always iron, the transporter is present, which can transport the divalent ion, not trivalent ion. Okay, that's why iron has to be transformed into, converted or transformed or reduced into ferrous. Okay, reduced into ferrous. Then again in the circulation, okay, circulation, okay, circulation, endothelial lining also present, transporter for divalent ion. Okay, it is transported inside the circulation. Again it is oxidized to transferrin, ferric state, because transferrin can transport only the ferric, can combine only 2 ferric iron, not ferrous. Okay, that's why. Then lost through skin, like that. In the plasma, it can involve in the hemoglobin synthesis, myoglobin synthesis, or it may lose during the any accidental bleeding, okay, or internal bleeding. Here also it can again use iron use in because I have already mentioned the non-heme and heme containing enzyme, iron sulfur complexes enzyme. It can use for the synthesis of those enzyme. Okay, or it can be remain as a ECF as 4 mg, okay, as the unbound iron, isn't it? And it can excessive iron, it can stored as a ferritin 600 mg, like that. Okay, now requirement of the iron. Daily allowance of iron for adult Indian is 20 mg, out of which about 1 to 2 milligram is absorbed. Okay, 2 milligram, 1 to 2 milligram is absorbed. Children between 13 to 15 years need 20 to 30 milligram per day. Requirements is high. Okay, pregnant women, the need is high, 40 milligram per day. Okay, transfer of iron and calcium from mother to fetus occur mainly in the last trimester of the pregnancy. Okay, in the last trimester of the pregnancy. So in that last trimester, requirement of the iron is more. Okay, because fetal demand is more, right? In the first 3 months of life, iron intake is negligible. After born, okay, after birth, the first 3 months of life, iron intake is negligible because milk is a poor source of iron. Okay, milk is the poor source of iron. Okay, it is a rich source of calcium but poor source of iron. During this time, child is dependent on the iron reserve received from the mother during pregnancy. Okay, because first trimester maximum iron is transfer, no, via the transplacental circulation, that fetus get maximum iron in the last trimester. That iron is stored, okay, in the first 3 months in the baby for the to fulfill the iron demand in the body. Okay, these are sources of iron. Sources of iron are leafy vegetables are the good source of iron. Pulses and cereals also contain lesser quantity of iron. Liver and meat contain good quantity of iron. Jaggery, remember, jaggery is a good source of iron. Milk is a very poor source. Now, factor influence the iron absorption. Please remember this one, iron metabolism always regulated at the level of absorption rather than excretion. Okay, iron metabolism is regulated at the level of absorption. Okay, there is no definitive excretion of the iron, isn't it? That's why absorption of the iron, during the absorption phase the iron metabolism is regulated. Okay, iron is absorbed by upper part of the duodenum. Okay, upper part of the duodenum. Reduced form of iron, only ferrous Fe2 plus form, that is the reduced form, is absorbed. Ferric form is not absorbed because the intestinal epithelial cell enterocyte, okay, enterocytes have the transporter that is specific for divalent cation, not trivalent cation. Okay, that's why always ferrous state, that is the divalent state, is absorbed, not ferric, remember, because of the transporter specificity, isn't it? That iron transporter, it is specific for the, it can combine only divalent cation. Okay, ascorbic acid, that is the active form of vitamin C. Okay, vitamin C, ascorbic acid. Ferric iron are reduced with the help of gastric hydrochloric acid and ascorbic acid. You know the vitamin C is strong reducing agent, that's why it is considered as an antioxidant. Okay, antioxidant. Okay, it is a strong reducing agent. Okay, that's why it is a good antioxidant. Okay, vitamin C. So ferric iron is reduced with the help of gastric, HCl and ascorbic acid, cysteine and sulfahydryl group of the proteins. Okay, sulfahydryl group of the protein. Now interfering substances are, which decrease the absorption of the iron, is phytic acid, okay, that is present in cereal, and oxalic acid. Okay, that is the interfering substance, phytic acid and oxalic acid. Oxalic acid present in the leafy vegetables. Other minerals, calcium, copper, lead, phosphate will inhibit iron absorption. Okay, calcium, copper, lead, phosphate will inhibit iron absorption. You can remember 1 atom of lead will inhibit absorption of 1000 atom of iron. How much is lead? So in the lead poisoning there will be reduced synthesis of the hemoglobin, okay, due to the reduced absorption of the iron by the lead. Okay, now mucosal block theory, it used to come as a short notes. Mucosal block theory. Duodenum and jejunum are the site of iron absorption. Okay, already I have mentioned duodenum and jejunum are the site of iron absorption. Iron metabolism is unique because homeostasis is maintained by regulation at the level of absorption, not by excretion. Okay, this one you have to remember. Iron metabolism is unique. Why? Because this homeostasis, okay, homeostasis is maintained by regulation at the level of absorption, okay, not by excretion. Okay, when iron stored in the body are depleted, absorption is enhanced. Okay, when the stored iron in the body are decreased, then obviously body demand will be more because body is depleting the stored iron. Okay, in that case absorption is enhanced. When adequate quantity of iron is stored, body has adequate supply of iron, adequate quantity of the iron, in that case absorption is decreased. Okay, just opposite. If it is quantity, if supply is more, then absorption is decreased. If supply is less, by the depletion of the iron, then absorption is increased, like that. This referred to as mucosal block of the regulation of the absorption of iron. Okay, only ferrous and not ferric at form of iron is absorbed. Okay, only ferrous form of iron is absorbed. Okay, ferrous iron in the intestinal lumen, ferrous iron in the intestinal lumen binds to mucosal cell protein. Okay, intestinal lumen binds to mucosal cell protein called divalent metal transporter 1. Okay, divalent metal DMT1, metal transporter 1, DMT1. The bound iron is then transported into the mucosal cell. Okay, the bound iron is then transported into the mucosal cell. Please remember this one. Okay, inside the mucosal cell, ferric iron is formed. Okay, it is absorbed as a ferrous iron. As soon as it's crossed the mucosal barrier, it's reached inside the mucosal cell. Again, the ferrous is converted to ferric. Okay, ferric form, and this ferric form is complex with apoferritin to form ferritin. Okay, this ferric form which is complex with the apoferritin, okay, to form ferritin. Very easy. This mechanism of iron absorption from intestinal lumen to mucosal cell is different from the iron release from the intestinal cell to the bloodstream. Okay, this mechanism of iron absorption from the intestinal lumen, that is the dietary iron, isn't it? Whatever iron we are supplying the body via diet. Okay, that absorption of that iron from the upper part of the jejunum and duodenum or duodenal lumen to the mucosal cell, to their mucosal cell, that is different. Okay, that is different from the iron release once it is absorbed to the mucosal cells. Okay, from the mucosal cell it has to be released to the bloodstream according to the body demand, isn't it? The release of the iron from the intestinal cell to the bloodstream, that is different. Okay, don't confuse. Different transporter. Okay, different transporter. For the absorption of the iron from intestinal lumen to the intestinal epithelial inside to the intestinal epithelial cell, into the intestinal epithelial cell, that transporter is DMT, divalent metal, okay, transporter 1. Okay, but from the mucosal cell to the bloodstream, that is iron is transported by the different transporter or different mechanism. Don't confuse. Okay, iron in the ferritin is released. So what happened in that case? Iron in the ferritin is released. Okay, inside the enterocyte, inside the mucosal cell, whatever iron is absorbed is stored as is converted into ferric and stored as a ferritin. Okay, when the time of the release from the mucosal cell to bloodstream, at that time that iron of the ferritin is released. Okay, and crosses the mucosal cell with the help of the transporter protein called different protein. Now it is ferroportin. Okay, ferroportin. Okay, different transporter, ferroportin. Okay, just opposite to the epithelial lining wall of the mucosal cell. Okay, this is the basolateral surface of the mucosal cell. Okay, ferroportin is present in the basal surface of the mucosal cell. Okay, that is DMT is present in the mucosal side of the, okay, this epithelial cell, mucosal surface of the epithelial cell. Okay, it is present in the basal part of the, okay, mucosal cell for the release of the iron, ferroportin. Okay, the iron crosses the cell membrane as ferrous form. Okay, again the iron crosses the cell membrane as a ferrous form. Okay, in the blood it is reoxidized to ferric state and transported by transferrin. Okay, this is the mechanism. In dietary iron, okay, dietary iron with the help of HCl, gastric HCl, okay, dietary iron in the lumen of the duodenum and jejunum, okay, upper part of the duodenum and jejunum, say intestinal lumen, it is reduced by HCl and, okay, ascorbic acid, vitamin C to ferrous state. Okay, ferrous state, and divalent metal transporter is there in the mucosal surface of the intestinal epithelial cell, also known as intestinal mucosal cell, intestinal epithelial cell. Okay, they are transported. Okay, once it is get inside the cell, okay, mucosal cell, or it is called enterocyte, okay, epithelial cell, it is get oxidized to ferric state. Okay, this ferric iron, it is stored as a ferritin. It combined with the apoferritin and stored as a ferritin. Okay, whenever the body demand is there and time to release from the mucosal cell to the bloodstream, that is the basal surface. This is the mucosal surface of the cell. This is the basal surface of the cell. It has to cross, okay, this mucosal cell barrier to reach the bloodstream, isn't it? So it is converted again to the ferrous, ferric iron again converted to the ferrous, and it is because ferroportin, ferroportin protein present in the basal surface of the mucosal cell can transfer only the ferrous state, not ferric state. Okay, it is crossed by the ferroportin to the blood. As soon as it reaches the bloodstream, it is oxidized to ferric by the copper containing enzyme ceruloplasmin. Okay, ceruloplasmin, okay, and as soon as it is oxidized to the ferric state, it is combined with transferrin and circulate in the blood. Okay, that is the story. This, after reaching the circulation, it is reoxidized by ceruloplasmin. It is a copper containing, either by ceruloplasmin or by the another molecule also there, hephaestin. Okay, hephaestin, it is there in the hair part. Its function also like ceruloplasmin. It is also responsible for oxidation of ferrous to ferric state, isn't it? Hephaestin. Regulation of the absorption by 4 mechanism. Now, mechanism of absorption, okay, from intestinal lumen, dietary iron from intestinal lumen to the intestinal epithelial cell, from the intestinal epithelial cell, how it is released to the blood circulation, in the blood circulation, how it is transported, already finished, isn't it? Now regulation, okay, regulation of the absorption, that is also by 4 mechanism, 4 important mechanism involved in the regulation of the iron absorption. Okay, 4 important mechanism, you have to remember that one. Okay, very important, 4 mechanisms. First one is mucosal regulation. Okay, in mucosal regulation, absorption of the iron needs divalent metal transporter, DMT, isn't it? And DMT and ferroportin. Okay, DMT in the epithelial surface of the intestinal mucosal cell or epithelial cell, and ferroportin in the basal surface, okay, towards the blood vessel. Okay, DMT responsible for the absorption from the intestinal lumen, and ferroportin, once it is absorbed to the cell, for the release we need ferroportin. For the release to the blood circulation we need ferroportin. Okay, so that is the mucosal regulation. So synthesis of both of these protein, okay, synthesis of both of these protein, DMT and divalent metal transporter 1, DMT and ferroportin, synthesis of both these protein is down regulated. Okay, down regulated means synthesis is reduced. Okay, synthesis is reduced or repressed or depressed, that is down regulated by hepcidin. Hepcidin is the another protein is there, another master protein. This is the master protein, hepcidin is there, which responsible for down regulation of the iron absorption by reducing the synthesis of this one, DMT and ferroportin, isn't it? Hepcidin indirectly, hepcidin responsible for the decreased absorption of the iron, because it down regulate the synthesis of these 2 iron absorbing protein, isn't it? So ferroportin synthesis will increase. Okay, if hypoxia or anemia, hypoxia means there is a lack of oxygen supply in case of high altitude, or anemia, there will be loss of blood. Okay, quantitative and qualitative loss of blood. In that case, body iron demand will be more. Okay, in the hypoxia, body iron demand will be more, and anemia, because of the loss of the blood, quantitative, either quantitative or qualitative, we need more iron. Body iron demand will be more. In that case, synthesis of hepcidin is reduced. Once synthesis of the hepcidin is reduced, this down regulation of the ferroportin and DMT will be, then down regulation of this iron transporter. Once the hepcidin synthesis is reduced, in case of hypoxia and anemia, then down regulation of this iron transporter protein by the hepcidin is overcome, isn't it? Overcome. Okay, overcome, or the down regulation is there, no more down regulation. Okay, down regulation is disappear. Okay, because hepcidin, there is no more hepcidin. Okay, no more excess hepcidin. Okay, or you can say there is no more the required amount of, okay, that is the appropriate required amount of the hepcidin to down regulate the iron transporter protein. Okay, so this down regulation is released. Okay, this down regulation of iron transporter protein is released. Okay, now body can absorb more iron, isn't it? More iron. Okay, once down regulation is released, then iron transporter protein synthesis will be more and body can absorb more iron. Okay, very easy. When demand of the iron will be more in case of hypoxia and anemia. Okay, then synthesis of, in that case, synthesis of hepcidin is reduced. Okay, then down regulation of this iron transporter protein by the hepcidin is released, isn't it, or disappear. So the synthesis of the iron transporter protein will be more, isn't it? So iron absorption will be more, like that. Number 2, hepcidin decrease the surface expression of ferroportin. Okay, in other way, again, hepcidin decrease the surface expression of the ferroportin, which is responsible for moving of the iron across the cell membrane. Okay, once the ferroportin, okay, expression is released, expression will be decreased, okay, in the basal surface. Okay, ferroportin is present in the basal surface of the mucosal epithelial cell, intestinal mucosal epithelial cell. One, hepcidin causes decreased expression of the ferroportin. This is ferroportin in the decreased expression of the ferroportin in the basal surface of the mucosal cell. Obviously, the iron absorption will be less, isn't it? Because of the decreased expression, decreased presence of the ferroportin in the mucosal epithelial cell. Ferroportin is synthesizing is normally, but is positioning is expression, okay, is positioning, is placement, okay, placement is deployment, okay, is expression in the basal surface of the intestinal mucosal cell will be less. As a result of that, iron absorption will be less, like that. Number 3, stores regulation. As body iron stores fall, the mucosa is signaled to increase iron absorption. Very easy. As the body iron stores fall, the mucosa is signaled to increase the iron absorption. Number 4, erythropoietic regulation. In response to anemia, the erythroid cell will signal the mucosa to increase the iron absorption. Okay, to increase the iron absorption. There is reciprocal relationship between synthesis of the ferritin and transferrin receptor. Okay, there is reciprocal, just opposite relationship between the synthesis of ferritin and transferrin receptor. Thus, when the iron level is high, ferritin is synthesized to store the iron. At the same time, there is no requirement further uptake of the iron. So, transferrin receptor is not synthesized. Okay, when iron level is high, synthesis will be more to store the iron, isn't it? At the same time, there is no requirement of the further uptake of the iron by the peripheral cell. So transferrin receptor are not synthesized, isn't it? So there will be reciprocal relation between the synthesis of the ferritin and transferrin receptor. Once it is stored, so further uptake is not required. So transferrin receptor, okay, transferrin uptake by this receptor, by the transferrin receptor synthesis will be less, okay, because there is no need to uptake of the iron from transferrin. This is important, okay. Iron transport in blood and uptake by cells, okay. I am going to repeat again, okay. Let's try to understand, okay. TIBC, okay. What is transferrin concentration? What is TIBC? What is transferrin saturation? Okay, you have to understand, okay. It is difficult, but if you understand, it will be easy. The transport form already I have mentioned. Once it is released to the bloodstream, it is carried by the, or it is transported by the transferrin, okay. Transferrin can bind ferric state of the iron, okay, 2 atom of the ferric iron, okay, 2 atom of the ferric iron. So this transferrin, it is a beta 1 globulin, okay. Transport form of the iron is transferrin, which is beta 1 globulin. Normal plasma level of transferrin is approximately 300 milligram per dl. Okay, don't confuse this one along with the TIBC, because in the most of you are studying in Vasudevan, right? Everybody can hear me?
Yes, ma'am.
Yes, in the Vasudevan, yes, in the Vasudevan there is one mistake. Okay, there is one mistake that the in the unit of the TIBC always measured in microgram per dl, not milligram. There it is given milligram. Okay, it is always microgram per dl or microgram per 100 ml, isn't it? Not milligram. Okay, there it was given, it is given and milligram. Okay, transferrin concentration, it is 300 milligram per dl, that is correct. Okay, you have to write down these figures. Okay, normal plasma level of transferrin is approximately 300 milligram per dl. Okay, sufficient, that is sufficient, this 300 milligram per dl transferrin is present in the normal plasma. That's 300 milligram per dl, which is sufficient. Okay, this 300 milligram per dl is sufficient to carry a total approximately 300 microgram of iron per deciliter. Okay, per deciliter of plasma. This 300 milligram per dl transferrin, okay, because one transferrin can combine with maximum, there is two binding site of the transferrin with the 2 ferric iron, isn't it? So 300 mg per dl, this transferrin is sufficient to combine with 300 microgram, not milligram, 300 microgram of the iron per deciliter of the plasma. These figures represent the total iron binding capacity of plasma, isn't it? This is not transferrin saturation. This 300 milligram per dl transferrin in the plasma, okay, normal concentration of the transferrin in the plasma 300 milligram per dl. This 300 milligram per dl is sufficient, okay, sufficient approximately to carry 300 microgram of iron per deciliter. This is the total iron binding capacity. Okay, indirectly it is mean, okay, indirectly it is meaning is what? Out of the 300 milligram per dl transferrin, all amount is not available. Okay, all amount of the transferrin is not available to combine with iron, isn't it? Only out of this 300 milligram per dl, only a fraction of the transferrin is, okay, is responsible to carry the or to combine with the iron, isn't it? Combine with the iron. That means all the binding sites of one transferrin has got 2 binding side of the ferric iron. Don't confuse. That means all the binding side of the transferrin are not occupied by the iron, isn't it? That's why the 300 milligram per dl is sufficient to carry only 300 microliter of iron per deciliter of the plasma. Okay, that is called TIBC. Okay, that means all the iron binding site of the transferrin, okay, not occupied by the iron or not saturated by the iron at a time, isn't it? This 300 milligram per dl, although its concentration is 300 milligram per dl, this concentration is sufficient to carry 300 microgram of iron per deciliter of the blood. Okay, this is the iron binding capacity, isn't it? This indirectly again we can tell iron binding capacity is the amount of the iron, okay, per deciliter of the plasma, okay. It is combined, it is the amount of the iron, okay, amount of the iron that is combined with the transferrin binding site, okay, binding form of the iron per deciliter of the plasma, like that we can say. Because whenever this 300 milligram per dl transferrin will carry approximately 300 microgram of the iron, obviously this iron will be bound in the, definitely bound with the transferrin. Okay, so TIBC indirectly the bound form of the iron, isn't it? Bound form of the iron per deciliter of the plasma, okay, or per deciliter of the serum. Okay, it is a bound form of the transferrin. Okay, that means at the same time all the binding sites of the transferrin are not occupied by the iron, isn't it? In iron deficiency the level is increased. Okay, in the iron deficiency the level is increased. Okay, in case of iron deficiency TIBC will be increased. Okay, one molecule of the transferrin can transport 2 ferric atoms. Okay, the binding sites in transferrin are not normally fully occupied, isn't it, or saturated. Only 30% of the iron binding sites in the transferrin are occupied. Okay, only 30%. Okay, out of 300 milligram transferrin can carry 300 microgram of the iron, that is TIBC. Okay, this figure responsible for 30% saturation, 30% saturation of the transferrin, 30% saturation of the transferrin. Okay, that means all the binding sites of the transferrin are not occupied. Okay, normally only 30% of the binding sites are occupied. Okay, because TIBC is always 300 microgram, isn't it? 300 microgram. Microgram, not milligram, microgram. This 300 microgram bound iron, okay, bound iron, this is the bound form of the iron, this TIBC. This figure TIBC is the bound form of the iron which occupy the binding sites of the transferrin. Okay, this 300 microgram of the bound form of the iron responsible to give 30% of the transferrin saturation, okay, or responsible to bind 30% of the iron binding site of the transferrin. Okay, that is the concept. Saturation can decrease to less 16 during severe iron deficiency. Okay, once iron deficiency is there, those transferrin saturation will be decreased. Okay, its binding site will be less frequently occupied. Okay, there is a saturation of its binding site will be decreased, isn't it? Or if the iron concentration will be more, then chances of the saturation of this binding site will be more. Okay, more iron molecules or more iron atoms are available to occupy this transferrin binding sites, isn't it? Okay, transferrin binding sites, bound form will be also more, isn't it? So transferrin saturation is calculated by following formula. Transferrin saturation equal to serum iron concentration. You please write down. Please write down, all of you please write down. In the next class I will ask. Transferrin saturation equal to serum iron concentration divided by TIBC, total iron binding capacity, total iron binding capacity is the bound form of the iron with transferrin. Okay, total serum iron concentration, okay, and bound form of the iron divided by bound form of the iron, TIBC, isn't it, into 100. This is the transferrin concentration, transferrin saturation, isn't it? And normal biological reference value of transferrin saturation is 30 to 35% of the TIBC, transferrin saturation. That means all the binding site, even though the two transferrin concentration is 300 mg per dl, okay, its all binding sites are not occupied normally. Only 30 to 35% of the TIBC, that binding sites are occupied. Okay, that is the transferrin saturation. Transferrin saturation equal to serum iron concentration divided by TIBC into 100. Normal reference value of transferrin saturation is 30% to 35% of TIBC. UIBC is unsaturated iron binding capacity, UIBC. UIBC is unsaturated iron binding capacity. This test determines the reserve capacity of transferrin. That means portion of transferrin that is not yet saturated with iron. Okay, reserve capacity of transferrin. So in case of different diseases, how it interfere with the iron panel, total iron, TIBC, okay, TIBC and transferrin, UIBC, transferrin concentration and ferritin. Okay, in iron deficiency, total iron concentration will be low, TIBC will be high, bound form of the iron will be high because the binding sites are available. Okay, binding sites of the transferrins are available and iron concentration will be low. So definitely there will be a less molecule to occupy the binding sites. So whatever iron is there, all are combined with the transferrin. Okay, that TIBC will be, that's why TIBC will be more. UIBC also will be high, transferrin saturation will be low. The saturation will be low, isn't it? And ferritin also low because iron is deficient. There will be no chance of storage of the, no question of storage of the storage form. Hemochromatosis and hemosiderosis, iron concentration high. Iron concentration is very high and TIBC will be low. UIBC also low. Transferrin saturation is high. Ferritin also high. Chronic illness, it is low or low normal. Here it is low normal. UIBC, transferrin saturation also low normal. And ferritin is high or normal. Hemolytic anemia, it is high. Iron is high as a result of hemolysis. Okay, lysis of the RBC, and there will be breakdown of the hemoglobin and iron are liberated. As a result of that, iron concentration will be high in case of hemolytic anemia. TIBC will be normal or low. UIBC also low or normal. Transferrin saturation is high and ferritin also high. Sideroblastic anemia, iron concentration may be normal and high or high. TIBC normal or low, low normal. UIBC saturation is high, ferritin also high. Iron poisoning, iron is high, TIBC is normal and transferrin is normal. UIBC is low, transferrin saturation is high and ferritin is normal. Iron transport in blood and uptake by cell. In the blood, ceruloplasmin is the peroxidase which oxidizes the ferrous to ferric state. Okay. Transferrin receptors are present on the cell surface. Okay, transferrin receptors are present on the cell surface which synthesize heme. The iron transfer complex is taken up by the body cells by the receptor mechanism. Okay, iron transferrin complexes is taken by the cells by the receptor mechanism. The transferrin receptor binds to the molecule, two molecule of transferrin. Okay, transferrin receptor again combined with the two molecule of transferrin. The iron transferrin receptor is internalized. Iron is taken by the cell. Storage form of iron is ferritin. It is seen in intestinal mucosal cell, liver, spleen and bone marrow. Where ferritin, iron is stored as a ferritin? Mucosal cell, already I have explained. Liver, spleen and bone marrow. Okay, the apoferritin can take up to 4000 iron atom per molecule. Ferritin contains about 23% of iron. Okay, if they can take up to 4000 iron per molecule, that ferritin contain about 23% of iron. Normal plasma contain very little ferritin. Ferritin in plasma is elevated in iron overload. Thus, ferritin level in blood, it is an index of body iron store. Okay. Thus, ferritin level in the blood is an index of body iron store. Okay, ferritin always estimated, blood ferritin, serum ferritin level always estimated by the chemiluminescent assay. Okay, chemiluminescent technology. Okay, estimated by chemiluminescent assay. Okay. In iron deficiency anemia, ferritin content is reduced. Hemosiderin. Hemosiderin also a storage form of iron which is more insoluble than ferritin. Which is more insoluble than ferritin. And iron is more slowly released. It is formed by the partial deproteinization of ferritin by lysosome and are found as aggregate in the tissues like liver, spleen and bone marrow. Okay, it formed by partial deproteinization of the ferritin. It is more insoluble than ferritin, so iron is more slowly released. Okay, this is the conservation of the iron in the body. As hemolysis occurs, lysis of the RBC, hemoglobin is released. Okay, hemoglobin, haptoglobin complexes taken by the liver copper cells. Okay, iron is released and reutilized. Then globin also removed. Then only heme. Then again in another this one, hemoglobin heme is released. Okay, heme is released. If the globin and heme is, there will be two chances. Either the hemoglobin is complex with haptoglobin complexes and taken by the liver copper cells. Okay, directly iron is reutilized after releasing there. Either or hemoglobin is breakdown by the heme oxygenase system. Okay, to heme and globin is removed. Heme complex with hemopexin complex taken by the hepatocytes. Here also iron is reutilized. After or heme is oxidized by the heme breakdown is by the oxygenation. Breakdown of the heme by the oxygenation by the heme oxygenase system. Okay, heme oxygenase, it is a multi-enzyme complex. Okay, heme oxygenase is the multi-enzyme complex. Okay, here porphyrin ring is open. Okay, cyclical porphyrin ring becomes linear porphyrin ring. Okay, because heme contain cyclical tetrapyrrole ring, no, this cyclical tetrapyrrole ring is open, so linear porphyrin linear tetrapyrrole are formed. Okay, where 4 pyrrole ring are arranged in head to tail manner. Okay, and bilirubin is released and ultimately they are converted to bilirubin. Okay, by oxidation. And iron is released and transported by iron transferrin. Okay, iron transferrin, and iron transferrin complexes is uptake by the transferrin receptor and they stored as a ferritin. Okay, or if requirement is there, that ferritin iron is released for reutilization. Excretion of the iron. Already I have mentioned iron is a one way. Iron metabolism is very unique because this metabolism regulated in the absorption level, not in excretion level, because excretion is very little, negligible. Iron is a one way element, so it is known as a one way element, that is very little of it is excreted. The regulation of homeostasis. Okay, homeostasis means constant equilibrium, iron equilibrium in the body. Okay, iron equilibrium in the body, equilibrium. Okay, equilibrium situation. Okay, equilibrium. The regulation of the homeostasis is done at the absorption level. Almost no iron is excreted through urine. Feces contain unabsorbed iron as well as iron trapped in the intestinal cell, which are then desquamated. About 30% of the cell of the intestinal lining are replenished every day, so this loss is considerable. All the cell in the skin contain iron. The upper layer of the skin cell are constantly being lost and this is the another route of iron loss from the body. Okay, there are chances of two route. There are chances of loss by the two routes. One is feces contain unabsorbed iron as well as iron trap in the intestinal cells. Okay, iron, which is then desquamated. 30% of the cell in the intestinal lining are replenished every day. Okay, so this is the loss is this. So this loss is considerable. Another loss by the upper layer of the skin. Okay, causes of iron deficiency now. Causes of iron deficiency. This is also important. Nutritional deficiency of iron. Okay, because there is deficiency of the food containing iron. Okay, deficiency of, there is a decreased intake of the food contain iron. Okay, so this leads to nutritional deficiency. Lack of absorption due to subtotal gastrectomy or hypochlorhydria, isn't it? Subtotal gastrectomy, because this one iron is absorbed from the duodenum and upper part of the jejunum. So in case of subtotal gastrectomy, that upper part of the duodenum and this one subtotal gastrectomy, the upper part of the jejunum and duodenum a little bit removed. Okay, there will be loss of the mucosal epithelial cell. Okay, so there will be lack of the absorption or hypochlorhydria. There will be decreased production of the HCl by the gastric mucosal cells. Okay, in that case there will be lack of absorption of the iron cannot be reduced because HCl and vitamin C helps in its reduction, isn't it? Only reduced form can be reabsorbed. A reduced form of the iron can be absorbed, already I have explained. So in case of hypochlorhydria, there will be less production of the HCl, so iron cannot be, ferric cannot be reduced to ferrous, so as a result of that there will be reduce of the absorption. Hookworm infection, repeated pregnancies, chronic blood loss, nephrosis. In case of nephrosis, haptoglobin, hemopexin, transferrin are lost in urine, along with loss of iron. Lead poisoning, okay, lead poisoning, iron absorption and hemoglobin synthesis are reduced. In turn, iron deficiency causes more lead absorption. It is a vicious cycle. Iron deficiency anemia. Now, iron deficiency anemia. It is the most common nutritional deficiency disease. About 30% of the world population is anemic. About 80% of the pregnant women suffer from this anemia. Maternal anemia contributes to the increased perinatal mortality. Okay. Iron deficiency is characterized by microcytic hypochromic anemia. Cellular site will be small, microcytic. Hypochromic, hemoglobin synthesis will be less, so hypochromic. Microcytic, hypochromic. Anemia diagnosed when hemoglobin level is less than 10 gram per dl or ferritin level is below 12 microgram per dl. Clinical manifestation of anemia: when the level is lower than 10 gram, body cell lack of oxygen and patients become uninterested in surroundings. Prolonged iron deficiency causes atrophy of the gastric epithelium, leading to achlorhydria, which in turn causes lesser absorption of iron. Very chronic iron deficiency anemia will lead to impaired attention, irritability, lowered memory, and poor scholastic performance. These clinical manifestations are very easy. You have to remember only. Chronic iron deficiency is manifested as koilonychia or spoon nail, like that. Koilonychia or spoon nails. Peripheral blood smear will take some target cells. These are the target cell, nucleated RBCs. Okay, target cell, teardrop cell, like that. Teardrop cell. Okay, nucleated RBC. Okay, and cellular size becomes small, microcytic, isn't it? Microcytic, and hemoglobin will be less hypochromic. Okay, it will be less stain. Okay, whenever you stain in the peripheral blood smear, it will stain less. Okay, it will absorb the stain less because of the hypochromia. Because of this, it will be late hypochromia. Why? This is due to lack of the hemoglobin synthesis due to iron deficiency. Treatment of iron deficiency. Oral supplementation is the treatment of choice. Oral iron supplementation is the treatment of choice. 100 milligram of the iron plus 500 microgram of folic acid are given to the pregnant woman, while 20 milligram of iron plus 100 microgram of folic acid to children. Iron tablets are usually given along with vitamin C to enhance the absorption, okay, by conversion of the ferric to ferrous form, okay. Administration of the iron zinc combination is beneficial to correct the deficiency of both. Iron toxicity now, okay, deficiency finish. Iron toxicity. So what is hemosiderin? Okay, hemosiderin, it is a, already I have mentioned hemosiderin, it is produced by the partial deproteinization of the ferritin. Okay, it is less soluble than the ferritin. So iron is less, so iron, the time requirement of the time for releasing of the iron from hemosiderin will be more. Okay, hemosiderin is a somewhat ill-defined molecule. It appears to be a partly degraded form of ferritin but still containing iron. It can be detected by histologic stain like Prussian blue or for iron, and its presence is determined histologically when excessive storage of iron occur. Okay, hemosiderin pigment is deposited in spleen, okay, spleen, bone marrow, liver, like that. Okay, hemosiderosis. Hemosiderosis is a fecal deposition of the excess iron that does not causes tissue damage. Okay, focal deposition of the excess iron, but it doesn't cause any tissue damage. When body iron is more than 25 to 30 gram, hemosiderosis is manifested. Okay, hemochromatosis. Now there is a difference between the hemosiderosis and hemosiderosis. Hemosiderosis, there will be focal deposition of the excessive iron which does not damage the tissue, but hemochromatosis will damage the tissue, isn't it? Hemochromatosis is the iron overload. It typically systemic process in which iron deposition can cause tissue damage. Types of the hemochromatosis. There are two types of the hemochromatosis. Remember, hereditary, that is known as primary hemochromatosis, and secondary hemochromatosis. Here in the hereditary hemochromatosis, there are different types and different causes. You have to understand because it will come as a short notes. Hereditary hemochromatosis, that is the primary hemochromatosis, is a very prevalent autosomal recessive disorder in certain parts of the world like Scotland, Ireland, North America. It is characterized by excessive iron storage in the tissues due to absorption of excessive quantity of dietary iron. Okay, why there will be excessive absorption of the dietary iron? Because there will be loss of the regulation of the iron absorption, okay, in the small intestine. Okay, as a result of the loss of the regulation of the absorption, iron start reabsorbing, okay, go on absorbing, and accumulation of the iron in the body, okay, lead to tissue damage. Accumulation of the iron in the different body tissues leads to their damage, okay, because there is a loss of the regulation in the iron absorption. As there is a loss of the regulation of the iron absorption, excessive iron is going on absorbing. Secondary hemochromatosis can occur after repeated transfusion, especially for the treatment of sickle cell anemia. Excessive iron intake orally or a number of other conditions, some other condition, okay, or excessive oral intake of the iron by African Bantu population people who consume alcoholic beverages fermented that container made of iron, container, okay, contain iron, like that there will be excessive consumption of the iron, but repeated transfusion is the main cause. Treatment of hemosiderosis. Repeated phlebotomy every week till serum iron and ferritin reach near the normal level. Desferroxamine, a chelating agent, forms the iron chelate with ferric to form ferroxamine, which is excreted in urine and stool, which form an iron chelate in the ferric form of the iron. Ultimately, ferroxamine in form, which excreted in urine and stool. This treatment is also used for the people where for those that phlebotomy is not possible, especially heart complicated, cardiac people is having cardiac complications, okay, and some other contradiction of the phlebotomy, okay. Now this iron overload condition, it is there in the Harper 31st edition. Hereditary hemochromatosis, okay. hereditary hemochromatosis, this is important. Hereditary hemochromatosis, that is the primary hemochromatosis. Okay, in the primary hemochromatosis, I have already mentioned there is a loss of regulation in the iron absorption. As a result of that, iron is keeps on absorbing, okay, resulting the accumulation of the iron in the various tissues leads to their damage. Okay, so that is the HFE related hemochromatosis type 1. Okay, HFE is the iron transporter protein. Okay, iron transporter protein. Okay, non-HFE related hemochromatosis, juvenile hemochromatosis type 2, hepcidin mutation. I have already mentioned that there is a loss of regulation of the iron absorption. Hepcidin, it is an important protein to regulate the iron absorption by down regulating the ferroportin and DMT, isn't it? I have mentioned hepcidin causes down regulation of the ferroportin and DMT. Okay, as a result of that, there will be reduced synthesis of the ferroportin and DMT. Okay, as a result of that, as the synthesis of the ferroportin and DMT will be reduced, the iron absorption will be automatically reduced. But here in case of hepcidin mutation, there will be defect in the down regulation. So there will be excessive synthesis, okay, excessive synthesis of the ferroportin and DMT. Okay, this protein start absorbing more iron. Okay, more iron. There will be loss of the down regulation by the hepcidin due to mutation of the hepcidin. Hemojuvelin mutation. Transferrin receptor 2 mutation. Iron cannot be uptake from the transferrin, isn't it? That because of the mutation of this receptor, transferrin receptor mutation. Because of this mutation, uptake of the iron is lost. Regulation of the uptake is lost, isn't it? Ferroportin mutation. Ferroportin, there is a mutation of the gene for the ferroportin. As a result of, there will be abnormal ferroportin will be synthesized, which causes more absorption of the iron, that is type 4. Okay, secondary hemochromatosis, anemia characterized by ineffective erythropoiesis. Okay, in that case, there will be repeated blood transfusion. Okay, the chances of the secondary hemochromatosis will be more. Parenteral iron therapy, dietary iron overload, already mentioned. Dietary iron overload in case of Bantu population which consume alcohol beverage that is kept on the iron containing container. Okay, miscellaneous condition associated with iron overload, alcoholic liver disease, non-alcoholic steatohepatitis, hepatitis C infection. These are the causes. So that's all about the iron absorption. Once if hepcidin is mutated, hepcidin gene is mutated, okay, there will be defective hepcidin will be formed. Okay, as a result of that, down regulation of ferroportin and DMT will be lost. Okay, as a result of that, increased iron absorption, there will be synthesis of the, if the down regulation will loss, that means increased synthesis of the ferroportin and DMT. As a result of that, there will be increased iron absorption. If increased iron absorption, then iron overload, it will accumulate in the tissue, resulting in the tissue damage. If the hepcidin again it is mutated, there is a defective hepcidin, there will be increase, because hepcidin causes the decreased expression of the ferroportin. Okay, decreased placement, decreased positioning of the ferroportin in the basal surface of the mucosal cell. As this hepcidin is mutated, okay, gene is mutated, the abnormal hepcidin will be synthesized. Okay, mutation of the hepcidin. Okay, so there will be increased expression of the ferroportin in the basal surface of the mucosal cell, which results in increased absorption of the iron. Okay, increased absorption of the iron from the mucosal cell to the increased expression of the ferroportin in the basal surface, which causes increased absorption, increased release of the iron to the bloodstream. Once it is entered in the bloodstream, it goes the various tissues for accumulation. Okay, excessive iron goes to the various tissue where the excessive iron excessive iron, okay, transported in the bloodstream will be disposed obviously in the various type of tissues, okay. So as a result of that, hemochromatosis results. So that's all about the iron metabolism. Any doubt? It is very important. Okay, iron absorption is very important. It will come as a long question also. Okay, and the iron overload, hemochromatosis, siderosis, it used to come as a short notes. Okay, so try to study. Okay, if any doubt, you can ask me in the next class. Thank you.